Welcome, dear all. My name is Muhammad Abdel Gawad, a nephrologist from Egypt. I'm a member of ISN social media team. It's my pleasure and honor to have this interview with one of the eminent nephrologists, Dr. Raja, Associate Professor, Department of Nephrology, Postgraduate Institute of Medical Education and Research, Chandigarh, India. Dear Dr. Raja, you will present a lecture at the next ISN Frontiers in Bergamo, Italy. Your lecture's title is Postpartum Renal Cortical Necrosis and Atypical Hemolytic Uremic Syndrome. I want to ask you some questions. First, pregnancy is associated with multiple complications that can induce kidney injury. Please tell us about these complications.
Thank you so much for the kind words. And I would start. You will all agree that pregnancy is a physiological state, but many organs are at the fringe in the sense that, the activities, there is an excess demand. So even for the kidney is one of that organ. And many a times what happens is when there is a compromised clinical care, most of the times, you have the kidney being affected. And, in these, the common situations are, hemorrhage and infections. You will agree that, both antipostpartum hemorrhage and postpartum hemorrhage, and similarly, post-abortal sepsis and purpural sepsis accounts for two-thirds to three-fourths of the acute kidney injury in the past. And fortunately, post-abortal sepsis is declining both in the low middle income and lower income countries. The another aspect of acute kidney injury is the hemolytic uremic syndrome. Hemolytic uremic syndrome is an underreported entity, and it's a testimonial to the statement that what the mind does not know, the eye does not see. Many a times, evaluation for the hemolytic uremic syndrome is never done. In the past, even our hospital was not comprehensively evaluating for hemolytic uremic syndrome. And when we started to look for, evidence of microangiopathic hemolytic anemia, we had startling results, which we will be discussing in the next subsequent questions. Yeah, please.
Thank you, Dr. Raja, for this comprehensive and summarized answer at the same time. Okay, what about postpartum cortical necrosis? Is it common, and how to avoid it?
So, conventionally, 2 to 3% of the garden variety of acute kidney injury progress to cortical necrosis, whereas it is 15% in cases of obstetrical AKI. So much so that in India, obstetric AKI is the most common cause of renal cortical necrosis, closely followed by envenomation induced, that is snake bite, and wasp sting induced acute cortical necrosis. And how could one avoid, renal cortical necrosis is a very good question, in the sense that there is a compromised clinical care in most of the situations which predisposes to cortical necrosis. So you have hemorrhage, you have infections, and most of the times they are telltale signs of, compromised clinical care. So if you have a good meticulous clinical care, I think we could prevent renal cortical necrosis even in a disadvantaged setting.
Yes, you are true. And I think that prevention is the best treatment for any disease,
Yes.
especially for the diseases that don't have actual management and actual treatment. Okay, you mentioned, Dr. Raja, that postpartum atypical hemolytic uremic syndrome is underreported. Do you think it is common? And if it is common, how it is possible to avoid it too?
Yeah. So, postpartum HUS, you could have two settings. One setting, you have somebody who is a known case of hemolytic uremic syndrome, is pregnant, and then there is a relapse of the disease in the third trimester or in the postpartum state. The second is, a patient who does not have any history of hemolytic uremic syndrome and develops it during the pregnancy, in the immediate, in most of the times in the postpartum period. And The latter is more common in the low middle income and the low income settings. And if you see the conventional reports, as I said earlier, less than 10% of the acute kidney injury is attributed in the pregnancy setting to, hemolytic uremic syndrome. However, if a close attention is paid to the microangiopathic hemolytic anemia, the results could be different. When we evaluated for microangiopathic hemolytic uremia, microangiopathic hemolytic anemia in our patients of pregnancy-induced acute kidney injury, what we found was 78%, that is 80% of the patient had evidence of microangiopathic hemolytic anemia along with the kidney injury, which would, settle for a diagnosis of hemolytic uremic syndrome. So the test that we did was nothing but a careful look at the peripheral blood smear for schistocytes or the fragmented cells, serum LDH levels, and then looking for haptoglobin. And indeed, most of the times we had brushed these patients as bleeding related or infection related. Actually, the bleeding or the infection were the predisposing factors in somebody who was genetically, had a variation or mutation to the complement genes. And again, C3, doing a C3 alone would not be contributory in these cases, because C3 is secreted in large amounts during the pregnancy, and it may be falsely normal in the pregnant state or in the immediate postpartum period. So the most critical element in this situation would be is to do a genetic testing to know the predisposition for the hemolytic uremic syndrome. Is it clinically important? Indeed, yes, because if you are able to diagnose hemolytic uremic syndrome quickly, you could start the patient on some sort of plasma exchange or plasma infusion therapy, because eculizumab is not freely available, and you could prevent the most catastrophic complications, that is cortical necrosis.
Okay, thank you again for this nice comprehensive answer. So as per the number of complications reported in the postpartum period, nephrologists actually have a big role in the management of these complications. And I think it may be needed to have a subspecialty in nephrology called postpartum nephrology job. Do you agree with this?
Indeed, yes. So it is a very important question. We have been looking into our acute kidney injury data over the last 15 to 20 years. And what we found was even the common entities like malaria-induced acute kidney injuries have gone down. But the pregnancy-induced acute kidney injury continues to be there. About 7 to 10% of all the AKI is because of pregnancy and its related causes, which traditionally has been because of hemorrhage or infection in the past. And indeed, most of the complications that arise in the postpartum period, but for the venous thrombosis, is going to affect the kidneys. Maybe that infection, or if there is a bleeding, or anything else, they are going to affect the kidney. Even so much that if the thrombosis is there and if it affects the renal artery or the vein, again, it's going to be the job of the nephrologist. As I say, if a limited attention is paid by the obstetricians in the postpartum period, and if the patient develops a complication, the job of nephrologist is going to logarithmically increase. And indeed, yes, at least in limited resources setting and low income countries and low middle income countries, it is very important to train the nephrologist to look into this aspect of nephrology, because we commonly see, even the nephrologist not evaluating for, the microangiopathic hemolytic anemias. And what happens is the patients then land up with us with cortical necrosis because they could have well been taken care of at an earlier stage of illness itself.
Yes, that's true. As you said, and as you mentioned, that the incidence and the prevalence of postpartum nephrology complications is not low. So nephrologists must be engaged more and more in these cases and in this period of the patient. Okay, can you give us a summary or a screenshots of your lectures during ISN for entire Bergamo?
Yeah. What I intend to speak is I'm going to delineate thrombotic microangiopathy or hemolytic uremic syndrome as a primary cause of renal cortical necrosis. Interestingly, we analyzed renal cortical necrosis in patients who presented to us who were referred with a diagnosis of bleeding associated or a severe infection associated cortical necrosis, and well, they didn't have a disseminated intravascular coagulation. So what we did was we evaluated them for hemolytic uremic syndrome, and we found the microangiopathic hemolytic anemia in most of the patients. And what the next subsequently we tested their genetics, if they had any genetic variations which predisposed them to develop hemolytic uremic syndrome. To our surprise, what we found that the Gordon variety of pregnancy acute kidney injury with cortical necrosis had genetic mutations or variations which predisposed them to develop hemolytic uremic syndrome and cortical necrosis subsequently. And the most common risk alleles was with CFHR, that is complement factor H related genes 1 and 3, and it was a gene duplication in them. So the pregnancy, the blood loss, and the infection was probably the second, third, or the fourth hit in these patients. And I think it is important to recognize this, because only if you recognize this, you will be able to, educate the internist and also the gynecologist for an early referral, and treat them early, so that they don't come to the nephrologist in case they start to develop kidney injury. Also, they could be taken care by the internist during the initial period itself.
Thank
So
you.
this is what I would be speaking. This is what I would be, the gist of what I would be speaking in my.
Yes, and I'm sure that we'll enjoy these lectures.
Thank
And the final question, and I think it is the most important, especially for the junior nephrologist. What continues to inspire you in the field of nephrology?
So it's almost my 12th year into the nephrology as a consultant, and what interests me is the immunology and the clinical association with the immunology. We run a primary glomerular disease clinic and a registry. So it's the immunology which inspires me to nephrology. And other than that, we have been able to provide a lifeline to patients who have failed their major organ system, and we our hospital caters to patients who come from a very impoverished background. We are able to provide them renal transplant at almost no cost. So we are giving them, or we are able to provide them a reasonable livelihood. So I think that's something which inspired me to join nephrology.
Dear Dr. Raja, actually it was my pleasure and honor to have this interview with you. Thank you again, and see you in Italy.
Thank you. Take care. Have a nice day ahead.